Assalamu alaikum. The long clinical consultation day. First scenario, Mr. James Anderson, 68 years old. His occupation was retired coal miner. Background of ex-smoker, 40 packs per year. History. Presenting complaint was increasing short of breath over 1 year. Words over the last 3 months. Associated symptoms, chronic productive cough, white sputum, occasional wheeze, fatigue, and unintentional weight loss of 5 kg over the last 6 months. Ready to start? Dr. Ayula, Dr. Maida?
Yeah. Hello.
Here you go.
Hello.
Hi, I'm Dr. Ayola. I want to be the doctors here today. Are you Mr. James Henderson, 68 years?
Yes, doctor.
All right. Thanks for coming to see me today. I understand you're having some breathlessness over the past 1 year. Is that right?
Yeah.
Okay. And we're going to be talking about that today and see how we can come to a diagnosis and management plan. Is that okay?
Yes.
All right. Could you tell me more about this, please?
Okay, doctor. Over the past 1 year, I observed that I become more short of breath. And the things that I can do before, now I can't do, to be honest. And I feel more tired, and it's bothering me, the cough as well. So I had a cough that's bothering me a lot.
Okay, and as this cough, let's start from the shortness of breath. Is this on exertion or as it worsens to on rest as well? At rest as well?
First, it was when I do activities, and now with minimum activity. And nowadays, it's even walking me in the middle of the night.
Okay, and have you got when you when you lie down at night, the shortness of breath now wake you up? Is that what you mean?
Yeah.
And you think you need to catch your own breath?
Yep.
Okay, and how long has this been worsening? Is it
over the past few? It's start since 1 year. To be exact, over the past 6 months, I feel more bad.
Okay, all right. Could you let's talk about this cough. The cough has been, how long have you been coughing for?
Say it again.
How long the cough has been for? How long?
For this 1 year.
1 year as well, and it's been worsened recently. Is that what you mean?
Yeah.
And you produce white sputum, some sputum?
Yeah.
Any blood in the phlegm?
Mainly white.
Mainly white. Okay, and there is any have you got wheezing as well?
Yeah, I hear some wheeze. Yes.
Some wheeze as well. Okay. Any leg swelling?
Yeah, I have some leg swelling.
Some leg swelling as well. Okay. And any pain in your tummy?
Not exactly.
Not exactly. Okay. And the swelling in your leg, has it been worsening as well?
Yeah, it is.
And is it more any time of the day?
It's not associated with a specific time, but I feel that when I am walking or something, it's get worse.
Okay. And when you rest, it improves, right? Is that what you mean?
Yeah, improve a little bit.
Okay, all right. And any chest pain?
No chest pain.
No chest pain. And and have you got, and just like a general question, really, to see how things have been ongoing? It might be a little bit complex. Any headache?
No headaches.
Okay. Any illness of your eyes?
No.
Okay. Yeah. And any change in your bowel habit?
Sorry?
Any change in your bowel habits?
No.
Okay. What about your chest? Have you got any form? Are you aware of your heartbeat?
No.
No. Okay. Just a little bit about your medical history. Have you managed for any medical condition?
Yeah, I have high blood pressure.
Okay.
And yeah, and my doctor before he prescribed some salbutamol, and I take them on and off. This is my medication which I take.
Okay. And have you been managed for any chronic cough in the past?
During this 1 year, when I go to my doctor, he prescribed this salbutamol. So I
Okay.
take them on and off.
Okay. Have you used antibiotics? The
Yes,
last one.
I used an antibiotic.
Okay. How many times in the last 1 year?
You can say 3 times.
3 times. Okay. All right. Thanks for that information. And you said you have high blood pressure. Are you on any medication for that?
Yep.
What
I'm taking Ramipril.
Ramipril. And how long have you been taking Ramipril for?
Yeah, this for a long time.
Long time. Okay. All right. Thank you. Do you take alcohol, Mr. James?
Yes.
Okay. Could you tell me how much of alcohol do you take?
I feel social in social occasions.
Okay. And do you smoke?
I do smoke, yeah.
Okay. Could you tell me how many sticks roughly? How many years have you been smoking for?
Okay, I smoking for 40 years, but at the moment I quit smoking.
Okay. All right. That's quite impressive. Well done. And how has this affected you? Is it affected in any way?
Say it again.
Has this affected you in any way? I mean, in your activities, anything you can do that you can do now?
The smoking, you mean?
No, I mean these symptoms. It seems
Yeah, it's affect me a lot. It's really affect me a lot. There is a lot of things I can do before, and now I can't do.
Okay. Who do you live with?
I live with my wife.
Okay. And have you been carrying on with your activity? Is she helping you? Is she supportive?
Yeah, she's very supportive. Yeah.
Oh, okay. That's quite well done. And what do you do for a job?
I'm retired now. I'm co-worker.
Co-worker. Okay. All right. And all right. Thank you, Mr. James. Is there anything that you think you might want to add to this conversation? Anything do you think we should talk about? Any question and any concern you want me to answer?
No, just what's causing these issues. I'm really concerned about what's going on here.
Okay, all right, Mr. James. Hopefully we'll be able to talk about that. There are a couple of things going through my mind, but I want to examine you at this point to see how is that all right?
Yep.
Okay. So I want to check for your I'm checking for your pulse. Okay. I'm also checking your blood pressure. I'm checking your hand. Okay.
So, what you are looking for, so I can tell you.
So I'm looking for a stained hand, smoking.
Yeah, there is
finger.
the stained fingers.
Okay, and also looking for if there's any muscle wasting in the hand, anything?
No muscle wasting.
No wasting. Okay, and any clubbing? Any finger clubbing?
There is mild finger clubbing.
Okay, all right. I will check your eyes. Any for pallor and jaundice?
No pallor or jaundice.
Okay, cyanosis in the mouth. Any cyanosis in the mouth?
There is central cyanosis.
Okay, all right. Thank you. I'm also checking for the neck for raised JVP.
There is JVP.
Yes, JVP.
Yes.
Okay, any right hypochondrial tenderness?
Any?
Right hypochondrial tenderness, any tummy pain, tenderness?
Yes, there is.
There is. Okay. So I will check for the, I also want to check the chest, examine the chest, looking for expansion. I'm also looking for the general appearance of the chest, checking for the chest percussion notes.
Okay, hyperresonant.
Okay, all true.
There is also, yeah, all through.
Okay, also I'm also checking for also I should have centralness earlier. Then I'm also checking for vocal fremitors.
Hyperresonant as well.
Very nice. Okay, and breath sound.
It's cuttered wheeze, but no crackles.
No breakers. Okay, bilateral lungs. Base of the lungs. Any crackles? Any crepitations?
There is basal crackles.
Basal crackles. Okay, thank you. So I'm checking the foot as well for pedal edema, for leg swelling.
Yep, up to tibia.
Okay, and also checking for the abdomen. I'm also going to check for any liver enlargement, any hepatomegaly.
Yeah, you can observe.
Okay, hepatomegaly. Then hepatic bruise. Listen to the surface of the liver. Is it smooth?
Yeah, smooth.
Okay, then I'm listening to the for hepatic bruise as well to see if there's any.
No.
But okay, all right. Thank you, Mr. James, for this for your patience with me, really. And yeah, after exactly after talking to you and the examination findings, there are a couple. I'm suspecting that might be might have a condition, likely there may be a condition called chronic obstructive pulmonary disease with core pulmonale. Basically, this is there's one of it that is going through my mind really, and it's basically expansion of your lungs really over time that may be predisposing you to the infection, recurrent infection that you are having. And because it's been long standing, it's suspecting that it might be affecting the right side of your heart. And that might have been the reason why you are having this the worsening of your breathlessness, the recent worsening in the breathlessness and the cough and the wheeze that you are having recently. That is what is quite going to my mind. But also putting in fact that you've worked recently in the you've worked before in the coal miner. I'm also suspecting, though it's like it's one of the possible things that is going through my mind, possibility of really some form of maybe possibly lung cancer really is a possibility here. We're giving a possibility, not that you have lung cancer yet. So we'll be doing some further investigation to be able to assess this, okay? And this will include some routine blood tests for you to see. And also, I will be admitting you first to. Are you with me, Mr. James?
Yes,
Have you
doctor.
got any question at this point?
Yeah, I'm just listening. I want to know that means I have heart issues as well.
Yes, I'm suspecting they may have to have heart issues as well, really, because of the lung issues that might be long standing and is affecting the right side of your heart. So because you are you've been having some worsening of the breathlessness and also swelling in your feet, some heart affectation, I want to admit you to relieve you of the symptoms first, okay, with some water tablets to get the fluid out of your lungs and also to relieve you of the symptom basically, and then we'll do further investigation to be able to arrive at this diagnosis. Are you with me?
Yes, doctor.
I'll be doing chest x-ray for you first, and also some also your lung function test is a lung function test to assess how well you are breathing, and also do a higher special scan for you to see how you are breathing. And we may need to call in the respiratory physician as well as the heart doctor to come and review you as well to see for their own input in your in the management. Does that sound like a plan to you, Mr. James?
Yes.
Okay, is it something you are considering to stay on for admission for?
Yeah, it's not specific, doctor. Just it's okay. I can be admitted.
2 minutes left.
I didn't get the last thing you said, Mr. James.
I'm okay to be admitted if this can help my symptoms.
Yeah, we hope that it's going to help your system if you work together. Then we'll daily weigh you to see how you are carrying on with this and daily assess your symptoms while we invite other specialty, the heart doctor, the kidney doctor to come and assess you, the heart doctor and the chest doctor to assess you. And then depending on the findings, we might have a further discussion on the ward to tell you what the further diagnosis is. But now we need to relieve you of the symptoms of breathlessness. Yeah. Okay.
Okay.
All right. Have you got any question?
No, I'm okay. Thank you.
Okay. All right. So the nurses will come and speak to you now. They would assess you and see and They will assess you and then look for availability of bed as well for you. Then we can carry on with your treatment. Okay.
Okay. Thank you.
All right. Thank you.
Okay, 50 seconds or 45 or 40 seconds left. You want to ask particular question?
Oh, okay.
You want
do you want to talk about advice about you told me you've stopped smoking, which is quite good, but we need to look at your diet aspect really, and also honestly yeah,
it's okay, perfect.
yeah.
Okay, let's go to the examiner question. Time is up almost. Okay,
Okay,
Dr. Maida, please start.
Okay, can you present your case?
Okay, this is a 60-year-old gentleman who is a retired coal miner and an ex-smoker who presented with shortness of breath, that is worsening shortness of breath for 1 year, with chronic productive with cough productive of sputum, and also with bilateral legs, evidence of fluid retention, evidence of right-sided heart failure. So I'm considering possible diagnosis of a pulmonary secondary to likely chronic obstructive pulmonary disease because of the clinical on examination. Sorry, he has evidence of hyperresonance chest with evidence of right-sided heart failure. So I'm suspecting he may have a core pulmonary with obstructive pulmonary disease. Another possibility can be entertained here would be bronchiectasis, because bronchiectasis and also evidence of possibility of a lung cancer in him. So
Okay. So you give the differential diagnosis as well. How you will investigate this patient?
For this patient, I want to do a pulmonary function test for the patient. Also I want to assess for the chest and as well as the cardiac symptoms. So I would do a routine blood that will include full blood count and kidney function test and liver function test as well. Then a chest X-ray. Also, a high resolutional CT scan of the high resolutional chest CT scan. Then a pulmonary function test as well to assess the function of the kidney. Echocardiography will be in place here, and heart scan will also be beneficial to assess the function of the heart and also the valves as well as the cardiac function.
Why are you specifically asking about the valves?
The valves, we do check the pulmonary valves as well as the tricuspid valve, tricuspid valve as well as pulmonary valve.
Why specifically you are concerned about tricuspid valve? Because
of likely have a core pulmonary, which is a backflow core pulmonary due to the pressure from the lungs causing a backflow of blood through the tricuspid valve, causing tricuspid regurgitation.
Okay, how you can manage this gentleman?
This gentleman, I want to admit him to relieve his symptoms, his cardiac symptoms, by giving him some diuretics, and also want to give some diuretics, and then sorry, please, down some diuretics, and then continue to if the diagnosis of pulmonary obstructive pulmonary is confirmed, I would want to give him some inhale salbutamol, and also inhales some SABA as well as LABA. And then depending on the form, if his ESR is inflammatory marker is raised and there's evidence of previous response to salbutamol, I also want to add inhaled steroid as well. Then give him some short course of prednisolone, short course of steroid, And if antibiotics is indicated in him, I also want to give a course of antibiotic after checking for the sputum. And if there's clinical evidence of infection or sputum culture show evidence of infection, I also want to start him on antibiotics. Then routinely monitor him with the pulmonary function test, and also do pulmonary function test. Yes.
Okay. So, what are other possibilities of managing patient with COPD?
Other possibilities would be surgical. You can also do some surgical yes, you can also do some surgical procedures such as lung volume reduction can also be given to such patients. And yeah, it's not
Okay, thank you. Is
Thank
still
you.
have time
Yeah, thank you.
for examiner questions?
No, time is up, but I want to ask here important question, Dr. Ayula.
Yeah.
You will admit this patient. Give me a strong indication for admission.
Indication for admission, the JVP is elevated. You have evidence of right-sided heart failure, fluid retention for this patient, is fatigue. And yeah, that's why I'm admitting him. Evidence of right-sided heart failure. The JVP is elevated. He has pededema and bilateral crepes. So I thought we should admit him to get fluid to relieve him of his symptoms.
Apart from right side heart failure, what other indication or what the most serious differential you are afraid from?
For him, I'm thinking of a pulmonary, possibly of pulmonary embolism can be a differential, yeah.
Okay, one more differential and I will finish the questions. Something serious, particularly with this patient.
Lung cancer.
Exactly, yes, that's it. I'm waiting for this to hear. Okay, fair enough. We can hear now Dr. Naida comment, then I will comment.
Okay. So I think first the taking history is okay. You start good. The only thing, this patient, he is a long-term smoker, and he has also a mining worker. So as Dr. Bassem said, cancer is a possibility. So I want to explore that more in the history by asking about if the patient has any fever, he has weight loss. You didn't explore the weight loss more, and you need, like, if he has lumps and bumps, any change in appetite. So to explore that, to show the examiner that you are thinking about the cancer as one of the possibilities. And the other thing that you didn't take a long history of the working, for how long he has been working, because it's still pneumoconiosis is a possibility in this patient. It can be like overlap between both COPD and pneumoconiosis. So we need still to explore more history in that patient. And I want to hear about, as far as this patient has COPD and previously has been treated with salbutamol, that means I will ask specifically, if he has been diagnosed with COPD, or there is any previous diagnosis of this disease, if there is any previous hospital admission because of the symptoms. So to assess how many exacerbation of the disease over the past 1 year, and this can give us the prediction of life of his long-term management as well. And because this patient sounds like this is long-term, that it has now he has right heart affection. That means COPD, most probably with these symptoms, either diagnosed or at least we have some work about it. If you ask me, he has 3 hospital admissions during this 1 year, and we need at this time to assess if he has any chest infection, why he has been admitted to the hospital, if there is any investigation about the chest infection, if there is any specific infection he has been treated for during this period of time, or what's going on. Regarding the social history, I think this man, he told you that he's not doing well during the things can do, now he can't do. I want to hear about what things now he can't do, because this patient most probably he needs social support. If his wife, what kind of still he needs some support at home. What things wife can do for him, and what things he can do by himself to see the CAT score of this gentleman. I also think about in examination, we need to listen for the parasternal heave, to listen for palpable second heart sound, and murmurs in the heart. So to assess the core pulmonal for this gentleman. This is mainly, I think, otherwise it's okay. I have no more comments.
Yeah, thank you, Dr. Maida. Very nice and very common case in the PACES exam. Lung cancer, COPD, bronchiectasis, occupational pneumoconiosis, all are the differential for this scenario. Okay, Dr. Maayula?
Yeah.
What you miss and what was defective in the history taking? As Dr. Maida said, I totally you missed the constitutional symptoms, loss of weight. Even loss of weight was written in the scenario, which is a clue for cancer, right? You missed it. You didn't ask how much for how long, how the appetite, lumps or bumps, fever, and night sweats, which is important and alarming sign for cancer. That's why I'm insisting to put the constitutional symptoms before going to the systematic or to systemic review. This is my favorite approach ever. To start with analysis of the complaint. You did that. The relevant system. Just and yes, there is some cardiac related symptoms you can analyze, but I agree to put it in the systemic review better. Why? To save some time. So you will start. Let's start about the. Let's talk about the optimum history taking in this scenario. So you will take history or the onset course duration of the cough and the short of breath. A very relevant system, that respiratory. So you will ask about wheezy chest, coughing up of blood, which is very important, relevant question in this scenario. This patient, if he coughed blood, means he has either cancer or bronchiectasis, right? This is what we know in basis. If he told you that I have coughed blood recently or before or whatever, so we'll suspect something serious in this scenario, and it will give you a clue regarding the lung cancer. So you will go forward to the next analysis, which is constitutional symptoms. I believe these symptoms will be positive in this scenario. Already written loss of weight. So you will, might have loss of appetite, you might have lumps or bumps, you might have night sweats and night fever. Then now you can ask about past medical history, which you already have been asked. She gave you history of cough and hypertension. Sorry, not cough. The hypertension and dry cough or cough related. You ask good question. Is it related to medication? She told you or he told you, yes, I took the medication. Maybe I'm not sure when the cough started after the medication or before the medication. You have to know the relation between the ACE inhibitor and the onset of the cough. Why? Because you might say in your differential dry cough as drug-induced ACE inhibitor. You can put it as a differential. But in this scenario, it's not dry cough, it's a wet cough. So it's away. It's not one of the differential. But take care. Maybe you have another case in another scenario, might be related to dry cough because of ACE inhibitor or drug-induced cough. Okay, just by the way, I'm talking about in general, not in this scenario particularly, but you have to know when this patient started on ACE and the cough duration. Is it before or the onset? Is it before or after? Just to know if is it related or not related. This is the second point, constitutional symptoms. Sorry, the past medical history after the constitutional symptoms. Now you can start systemic review. You started asking about the headaches. That's it. You didn't ask about weakness, pins and needles. What do you think the relation between pins and needles, vision, and weakness, maybe ptosis? What do you think?
Maybe it's superior vena cava syndrome.
Okay, one of the possibility because of cancer as well. Another complaint, or sorry, another differential or another condition or complication, what's called related to tumor also in the apex.
Lambert-Eaton.
Not Lambert. Yes, okay. One of the yes, okay. As paraneoplastic, perfect. What else? Important. Pancreas tumor. Ptosis, anhidrosis, meiosis. What's called? Horner syndrome. Right?
Yeah.
Yeah. So you might have what I mean. It's not. Yeah, Horner syndrome. So what I mean, you have to be more. You have good time, by the way. You have 3 minutes explaining the condition, what to do, the advices. Means that there is something defective in the history taking. The systemic review, it can give you it can open the window for other complication which is not explored by the patient. So you can ask about these things. You ask about the vision, which is good, but you can ask more about the CNS as paraneoplastic. So you can ask about pins and needles, weakness, or any vision problem. Then the endocrine system here, I don't think there is something important. Then the chest already asked as a relevant. The heart, now you have to ask about question for the cardiac symptoms. You ask about leg swelling. You want to say this is core pulmonale, which is perfect. You want to ask about, or you asked already about the awareness of heartbeat for anemia because of maybe cough or palpitation due to the pulmonary embolism. You can put it one of the differential if the patient is having palpitation. You analyze more about the short of breath related to the exercise or no, which is also can be ischemic heart disease complication. Then the GI. You ask one question only, any bowel change. The patient told you I have tummy pain, right? You have to know what is the cause of this tummy pain. Maybe some lymph nodes, liver, metastasis. You don't know, right? So you can ask more. Any tummy pain, any distension, any change of bowel habit, any difficult swallowing. This patient might have cancer and mass, and he has difficult swallowing because of compression by this mass. So what I mean, you can ask more in the systemic review, more questions, not only one question in every system. Even you know the disease. I know you put a differential in this scenario is COPD, but still we have a wide range of differential. I mentioned earlier, and I will repeat it after the end of the history taking. Next system, genitourinary ineforousness of the urine. What do you think the problem of the urinary system questions here?
Reduction in urine output.
This patient, yeah, this patient is hypertensive, right? He might have hypertensive nephropathy as a complication. So at least any nephropathy, any change of the amount, any change of the color, right? This patient might have some renal stones because of medication he's taking. What I mean, don't take it lightly. Don't take concise history taking. What you did as concise history taking. Focus on the respiratory part only, but you don't know about the all other systems. Skin rash is important. The joint pain. Do you think there is some relation between skin rash, maybe vasculitis, maybe related as a differential? Either yes or no. It's not a must, but I mean, you can ask all this question as yes or no. If no, quickly finish to the family history, travel history important, yes. The HIV question, I believe HIV one of the possibility as a differential. If this patient is losing weight, he has chest infection, recurrent chest infection, he might be HIV, right? You can put it as a differential. So you can ask about the risk factors of HIV. You have any casual relationships? You have any recreational drugs used, right?
Yeah.
So you have to go through these questions. I already post a video for my approach, which will never miss any of these questions if you go through all the steps. Okay, the last question, the occupational history. The job, as Dr. Maida said, you have to know when he stopped the job, for how long he was working as coal miner, because you can put a differential of coal miner pneumoconiosis or occupational pneumoconiosis as a differential. Smoking already written there, and he told you I stopped, which is good step. The alcohol, also important, if he's drinking extra or heavy drinker or binge drinker. Then the impact of his disease on his job, already you asked, and the examination. The examination was good. You did focus examination about the chest, but by the way, you have to do the whole chest examination steps. Inspection, palpation, percussion, auscultation. Okay?
Mhm.
So the inspection, any scar there, any change, the deformity of the shape of the chest, the palpation for the expansion, front and the back, and better to start from the back because you might have a lot of finding on the back. The percussion, of course, hyperresonance as you did, and the auscultation for wheezes or any crackles. There is some wheezes, of course, scattered wheezes. You can also hear some change of the focal resonance. Maybe there is a mass or consolidation related to the cancer or mass. You don't know. So you have to do examination in all steps of chest examination. The lymph node examination here is crucial important.
Mhm.
You didn't offer any lymph node examination, right?
Mm-mm.
So if you felt one lymph node or two groups of lymph node, axillary, vertical, supraclavicular, clavicular, cervical, you can put definitely lung cancer one of the differential, right? Okay, so this is what you miss. Sorry if I'm talking roughly about the missing and defective, but the missing and defective part you will work on to improve history taking. You finish the whole history taking and examination in 10 minutes, and you have 5 minutes extra. You can do a lot of history taking and other parts of examination. The murmur, as Dr. Maida said, you have to examine for all murmurs, the parasternal heave and pulmonary hypertension. As pulmonary hypertension signs, you have to auscultate, and the leg swelling as well for core pulmonary. Raise GVB, of course. I think these are the whole steps of examination in this scenario. I finish my comment. Again, the differential. So in order, and always, Dr. Ayula, you have to show the examiner you are rolling out the most serious complication. They want you to mention the serious complication either to the patient or to the examiner. Why? Because if you miss one of the differential, which is most serious, and this patient went home, for example, and he died or he missed the diagnosis, he came later on complicated with another complication like hemoptysis, so you will be in trouble. You didn't diagnose him earlier when he visited you initially. So you have to put the most serious differential, which can make sense about the scenario, and to roll it out either by questions or examination. And again, put it one of your differential to the patient when he asks you, doctor, do I have something serious? Why not? Yes, you have most probably something serious. It might be cancer, it might be HIV, it might be what's called COPD, it might be pneumoconiosis, occupational one, bronchiolitis obliterans, there is some wheezes, bronchiectasis. All this differential makes sense, by the way, But which is the first? You have to put the most serious differential first. You got it, Dr. Ayula?
Yes, thank
Any
you.
question? Any doubt?
No.
Okay. Regarding pulmonary embolism, yes, there is possibility of pulmonary embolism if the patient is having cancer. Why not to be as a complication to the cancer? Because cancer, as you know, procoagulant disease, so it might have, or this patient might have pulmonary embolism, particularly if this patient is having palpitation. If this patient presented with severe chest pain, acute onset, you can simply say, yes, pulmonary embolism, one of the differential diagnosis in this scenario. However, this scenario patient presented with long duration, so pulmonary embolism in this scenario is in the low of the, or the at the end of my differential, not at the top. Okay? You have any question or suggestion or doubt?
No question. Thank you.
Okay, Dr. Ayora. By the way, it's Will as a first time presentation with me. I think this is the first scenario to practice with me, right?
Mm-hmm.
Yeah, but it's looks better and organized. You took good history and the systemic review timing was okay. The examination, but it was little bit concise. I want to take more detailed history to do also more detailed examination, particularly the affected system, which is the chest. That's it. If you train on that, you will be perfect. When you put the differential, put the most serious and most related one, then the other differential. If you do this, you will get full mark, hopefully. Okay?
Yeah, thank you so much.
Most welcome, then. Thank you too. Any question, Dr. Mayada? Any added point? Any suggestion? Any missed
No,
points?
I think it's okay.
Okay. Please, Dr. Ayula, you can post the scenario to Dr. Maida, and I will read the comments. Anyone has comment, please, he can verbally present. Any suggestion, any question? Okay, I will read. Dr. Samoha, yes, Horner syndrome related to pancreas tumor, of course. Dr. Kinana, treatment, non-pharmacological, also family history. Yes, thank you for reminding me. This is not only your mistake. All of us, whenever the examiner asks him how to manage this patient, the first thing come to your mind, the medication, how to give, what to give, and the dose, the numbers. But this is wrong thinking. How to start managing any patient and how to tell the examiner and to convince the patient that the examiner that I am organized doctor, start by the non-pharmacological. First, education, counseling, because you have to tell the patient about the diagnosis. You have to tell the patient about the complication, how to deal with this medication and how to deal with this disease, how to deal with the possible complication might happen, how to deal with his daily activity. All these words and advices give you a good mark and also save some time. And also utilize the time not to be asked about the pharmacological option. Some examiner, when he asks about the pharmacological option, you don't know what's ongoing in his mind. So he will mention a lot of medication, but he is still waiting for one medication. If you give him this medication, he will give you the full mark. If not, he might minus you. So the best way is to start with the non-pharmacological, utilize your time, consume some minutes, some seconds. He might either forget about the pharmacological option, or at least he will know that you are organized doctor. You are giving a lot of steps, which is not only pharmacological. So always start with the non-pharmacological. When you go to the pharmacological, remember the complaint. What this patient presented with, the short of breath. So how I can manage patient with short of breath? Of course, admission. Then, according to the finding, the investigation, the diagnosis, might need oxygen, might need bronchodilator. If I want to talk about the pharmacological, I have a lot of options. The sputum culture based on I can give patient antibiotics, for example. I can give this patient diuretics for core pulmonary. So you have a lot of options, but you don't know what's ongoing in the examiner mind, what he wants to hear from you. But when you start to manage with non-pharmacological, never ever he will say you are wrong, because you started to manage the patient systemically, right? Any patient, I should start with non-pharmacological options. So he will not minus you, but if he asks you how to manage this patient, and you start to manage pharmacological option, and you give option he doesn't want to hear, definitely he will minus you. Or you might mention medication, which is not important in this step, he will minus you. I believe you have to start with the systemic review, the systemic way, non-pharmacological, and later on the pharmacological option. And according to the presentation, you can give the medication accordingly. Okay, the next comment. Okay, I will read the scenario first
Doctor,
for you,
can
Doctor.
I comment?
Yeah, sorry?
Doctor, can I comment?
Sure, yes.
Regarding the treatment, as you said, non-pharmacological and pharmacological and surgical. I think in respiratory case, we must comment on the vaccination and pulmonary rehabilitation program. I think this is very important. And in the COPD, we not forget the long life oxygen therapy. Thank you.
Perfect. Thank you, Dr. Al-Huda. Yeah, I think comment to the target. Whenever you have COPD patient, you can add to your management plan oxygen, stop smoking, and vaccination program, rehabilitation as well. Yeah, you're perfect. Yes, you have commented perfectly. Of course, you have to remember all these things. By the way, what I am trying to say is not the optimum, but I'm trying to make the things organized and systematic. But if you will comment in general, you have a lot of pharmacological options, you have a lot of non-pharmacological options, the vaccinations, it's a lot. But you have to start with the correct diagnosis first, correct differential, and accordingly, you will have the mark. So if you say this patient need to be admitted to rule out cancer, yes, you can get good mark in your differential and in the welfare. But if you say just this patient might be a chest infection, one of the differential. For example, I'm not saying this is the correct, but if you mention that, so you forget everything and you are thinking about, for example, pneumonia, it's wrong thinking. So you have to suspect the most serious here and most related and the most differential makes sense about the case. Loss of weight with cough, with long history of exposure to coal miner, smoker, clubbing, and skin tag for for smoker, heavy smoker. I mean, so it's equal to cancer. You have to put it one of the first differential. Thank you, Dr. Al-Huda. Next, I will read the case for Dr. Maida, then I will comment the last. Mr. Smith, 48 years old. You are the endocrine clinic. The task, history, focus, examination, and answer any concern. Mr. Smith, 48 years, presented with complaint of polyuria with fatigue, blood pressure 160/100, pulse rate 80, temperature 37.6. I will read the last comment, Dr. Maida, and we can start if you are ready. Dr. Zoom user, I don't know the name. Very important to ask detailed occupational history related to co-worker, of course, for compensation, legal right for the worker to get compensation if pneumoconiosis and silicosis. Yeah, this comment is perfect. And to the target, whenever this patient raise the issue of compensation, but not in the long clinical consultation. It might be in the communication scenario or the communication station. If this patient presented with these symptoms, you might raise the issue of compensation. But I don't think there is time in the non-clinical consultation to raise the issue of compensation while the patient is gasping for air or short of breath, loss of weight. It's no time, or this is not the time to explore the issue of compensation. It's a legal issue, yes, but in the communication scenarios, not in the non-clinical consultation. So I will refer the patient to legal issue. You can put it one of the multidisciplinary team approach, but it's not important to raise it to the patient while discussing. You don't have the time to do it, by the way. If you focus on this, you will forget a lot of things. So it's not the thing can give you the mark compared to the, for example, admission plan, the investigation. By the way, we didn't talk about the investigation, but again, as I already, every station, I put them in the systemic way, started by general, specific, bedside, image, and invasive. You can put in every investigation and every category, you can put at least 3 or 4 investigation. For example, the invasive one. For example, the invasive. What's the option of invasive, Dr. Ayula? If you suspect or if you want to give option of invasive investigation to this patient, what you could do for this patient? Dr. Ayula.
Invasive investigation.
Yeah. You mentioned already the image, a high resolution CT chest. You mentioned the, for example, the specific, you can say sputum culture, you can say pulmonary function test, but pulmonary function as bedside test, ABG as bedside.
Mm.
But invasive, I particularly focus on the invasive because it's important. It might give you the diagnosis if you do.
Okay, I'm not quite sure right now.
Okay, so always suspect or think about invasive mean you will pass a needle to the patient, inject something, advanced image, camera scan. What do you think? What camera scan you can do for this patient as invasive?
Maybe bronchoscopy.
Perfect, yes. You might do bronchoscopy for this patient? Do you think?
Yeah.
Yeah, exactly. You can take example, you can do
Biopsy.
bronchoalveolar lavage, you can do, exactly. Even you can take a snip from a mass. If you suspect a mass, you can do CT with contrast to diagnose if there is cancer or there is mass. So you have a lot of investigation. Pulmonary function test, of course, on the top. And what do you think the pulmonary function test in this patient?
Obstructive pattern.
Yeah, there is wheezes, so you can say obstructive pattern. You might have restrictive pattern as well.
Yeah, possibly. Yeah,
Possible,
mixed.
yes, exactly. Why? Because pneumoconiosis.
Mucormycosis.
Exactly, one of the restrictive disease as a fibrosis. I think we cover the topic from not from A to Z because there is a lot of question regarding the pneumoconiosis, but it's don't think more about the questions for pneumoconiosis. You will not go deep in details about pneumoconiosis if this is the case. At least to mention the differential, the investigation, and for the treatment for the pneumoconiosis. What do you think, Dr. Ayula? The definite treatment of pneumoconiosis, if this is the case. Dr. Ayula?
Yeah, I'm with you. I'm just trying to see.
Okay, pneumoconiosis, any fibrosis or any lung disease, occupational lung disease. When
Steroid?
Sorry?
Steroids?
Steroid, maybe early stage.
Early stage.
Yeah, at early stage, yes, it might help, but at the, I mean the definite.
Antifibrotic agents?
Okay, if there is fibrosis.
Yeah.
But as definite, already the lung damage. Yeah, that's it. So the definite for any lung fibrosis or pneumoconiosis, maybe the lung transplant. Just I give example, but it's not the old question for the management. You mentioned the steroid, yes, antifibrotic measures, yes, one of the options. But accordingly, not every disease will give this medication. But in general, you can give the management plan as pharmacological specifically for this case. Okay. Thank you, Dr. Ayula. Well done.
Thank you.
Yeah. Get ready for the next scenario to be a surrogate. You are ready?
Yeah.
Dr. Maida, ready?
Yes.
Okay. Anyone has comment, please post it in the chat box. I will try to read it later on. Yeah, here you go, Dr. Maida.
Okay. Hi, hello. My name is Dr. Maida, one of the medical doctors. Just I want to confirm that you are Mr. Smith, 48 years old.
Yes, I am.
Okay, Mr. Smith, can you tell me what brought you to the hospital today?
I've been to my GP and I noticed that because I've been having passing a lot of urine both day and night. It's been getting worse, and at least during the day I pass about 8 times a day, and at night about 6 times a day. And I've also been getting weak recently. It's been getting worse as well. So I'm just wondering what might be the reason for this, and if you could help me.
I'm so sorry for this. Can you tell me, since when you observed that you have these issues with the urine and fatigue?
Urine has been going off about 6 months, but it really started to get worse about 1 month ago.
So you observe that it's increasing over the past month?
Yeah.
Okay. You told me that during the day and the night, how many times at night you woke up from sleep for urination?
About 5 to 6 times at night and 8 times during the day. It's really disturbing.
Okay. Can you tell me, is it large amount or just the frequency of a small amount?
Large amount, large volume. Sometimes I put pass up to about 1 liter at a go. It's really, really disturbing.
Is it clear? Can you tell me about the color of this? Is it clear or dark?
It's clear. It's clear and not floody.
Not worthy. Okay. Do you have any urgency with that? I mean, that you want to go to the toilet, very urgent with these symptoms?
No.
If there is any burning sensation?
No.
It is the first time, or you had this before?
This is the first time.
Okay. Is it worse in a specific time on the day or just all over the day?
I can't say anything because I pass this both day and night.
Okay. So I think that's it. Your sleep at night is terrible, isn't it? So sorry for that. Do you notice any I mean, I'm now concerned about how you keep yourself hydrated. Do you drink more water?
No, I don't think so, because I only have to be drinking a lot of water just recently when I know, just to keep myself hydrated. But I don't think it has anything to do with that.
Okay. Do you observe any weight changes?
Not really, no.
I mean, any weight loss or gain of weight at all?
No, I've not noticed that all over my body, but I just noticed that my hand is getting bigger.
Okay.
Yeah, but I don't think I've gained weight all over my body.
Just your hand or any other part of your body?
Just my hands, and my wedding ring is not fitting anymore.
Okay. And this also over the past few months as well?
Yes. In the last 6 months.
Okay. And what about your appetite? Any appetite changes?
No.
Okay. Do you have any sweating or do you have any heat intolerance or cold intolerance?
No, I don't have those, but I think I've been sweating more these days.
Okay. Any skin changes?
Yes. I could notice some darkness around my neck.
Okay.
Yeah, and my armpits. Yeah.
Can I have a look?
Yeah, sure.
Okay.
I'll just send the pictures to you in the. Yeah. Can you continue so that I will just send the image to you?
Okay. Do you have any vision changes?
Yes, please.
Can you tell me exactly what changed with you regarding vision?
My vision, I think I've been having some double vision recently when I'm looking at stuff. It's just really distressing. I've been seeing my optician about that.
Do you observe that you have any headaches?
Yes, please.
Okay. Can you tell me more about that headache?
Headache is everywhere. It comes and goes really, but it's getting worse recently. And it's worse in the morning. Yeah, I think it's worse.
If I give grade of pain from 0 to 10, how you can grade the pain of this headache?
I would say 5.
Okay. If it change by, I mean, if you cough or you go to toilet, for example, if it change by that?
Oh, yes. When I go to toilet, I just feel like it just increases. When I cough, I feel more with the headache. Yes.
Okay. You send the picture?
Oh, sorry. I've been engrossed. Okay, I'm sending it now. It's coming in now.
Okay, no worries. Apart from that, can you tell me, I may need to ask some questions that it sounds a little bit personal. Do you have any problem with your erectile function?
Oh, doctor, that's been going on as well. I'm just shy to talk about that, really. Yeah, it's been going on for about the same time. Yeah, difficulty in erection. Yeah.
Okay, so you are suffering from that part as well. Can you tell me what about your desire? If there is any change recently?
No, no. I feel like, but I can't.
If there is any change in your urine stream, I mean, if there is any hesitancy or dribbling?
No.
Okay. Just I want to ask, do you have any chest pain or palpitation? I mean, awareness of your heartbeat?
No.
Okay. Did you have any short of breath?
Oh, no.
Yeah, you told me that you have some headaches and we talk about it. Can you tell me do you feel that you become more confused recently, or anyone said that to you at all?
No.
Do you have any tingling sensation or any numbness?
Yes, I do have sensation in my hands and foot.
Okay, mainly in the hand and foot.
Yeah.
Okay. Do you have any fever?
No fever.
Okay. Do you ever recently with these symptoms, you been prone to infection more?
No, I don't think so.
Okay. Do you have any illness I should be aware of?
Any what?
Any illness I should be aware of?
Yeah, I've been having well, I don't know if it is important anyways. I've been on I've been on omeprazole for quite some time now. Yeah, because I've been having some reflux. My GP placed me on that. And also I have hypertension and I'm on medication as well. I'm on Ramipril.
Okay. For how long you have this high blood pressure?
For 1 year.
1 year. If there is any recently, is it become uncontrolled, or since beginning it's uncontrolled? Because I found that it's a little bit high reading today.
No. No, I'm not quite sure. No one has told me that.
Okay. So you are not regularly observing your high blood pressure?
No.
Okay. Okay. Do you have any hospital admission for any reason?
Yeah. Yeah. I was admitted about 6 months ago because I had I have a tummy pain, and I think I have a something called renal colic at that time. Yeah. So I was admitted for a few days.
And what they said, what was the diagnosis at that time?
He said renal colleague, and I should keep an eye on it if it's come back again. But I got relief at that time.
Okay. Okay. Do you have any joint pains?
Yes, doctor.
Mm-hmm.
They have both.
Can you tell me exactly which joint that you have this pain on?
Both my knee joint, elbow joint. Yeah, but it's worse on my knee.
Mm-hmm. Any back pain?
No, doctor.
Okay. Okay. Can you tell me, do you have any family history I should be aware of? Something specific in the family at all?
Yeah, my sister was diagnosed of a brain tumor, cancer. I'm not sure if it's cancer or tumor. I'm just worried, yeah, because I'm having this headache. Yeah. So that is what I have, yeah.
Okay. Okay. Can you tell me, what do you do for a living?
I work as a secretary, but I've not been able to focus on my computer very well of late, so I've not been going to work in the last 3 months.
I can imagine that. I can imagine that. And now, what are you doing?
I'm just home.
Okay. We can refer you to occupational therapist to help you in that. I think these symptoms affecting your job as well. Do you smoke?
No, doctor.
What about alcohol?
Occasionally, socially.
Do you have any, sorry to ask this question, but we need to ask sometime. Do you take any recreational medications? I mean,
No, doctor.
help you in any part? Okay.
No.
What about your, you told me that you have these issues with the erectile dysfunction. How this affect your sexual life?
Yeah, it's affected. Well, it's affected it really. My partner, my partner is not quite happy with this.
Okay. Okay. Now can I examine you?
Yeah, sure.
Okay. So first I will start by general look for the patient. I am interested to see the hands, and I will have a general look for the face of this gentleman, looking for any coarsening of facial features, like prominent jaw and a large nose. And I will ask the patient to protrude his tongue to see if there is any macroglossia. I will look for frontal posing and the wide space teeth. This is by general look. If there is anything.
Yeah. I'm sending the picture. They has I'm sending the picture of the hands.
Okay, just a minute. I can't see.
Okay, I'm sending in the WhatsApp.
Okay. Just a minute. Really? Yeah. Okay. Then I will examine the pulse, and then I will take the blood pressure.
Elevated blood pressure.
So the blood pressure is
160/100.
100. I will ask for. I will offer that I need to check for blood glucose level.
Check for what?
For blood glucose level, BM.
I didn't quite get that, please.
blood glucose level. I will offer that. I will ask.
Blood sugar.
Blood sugar. Okay, blood glucose level. Okay, blood glucose level. Okay, elevated. Right. Blood glucose level is 11.7.
2 minutes left.
Okay, I will quickly examine the. I will examine the chest, and I examine the heart, and first.
Even the text is even.
What you said?
Even.
Okay. And then I will examine the base of the lungs, if there is any crackles or any sign of heart failure. And then quickly I will examine the legs. Okay.
Thank
Can you
you.
tell me your concern?
I'm just concerned what might be going on with me, and honestly, I don't know what. And if that is known, could I be normal if I'm treated again? Because I'm just worried about my hand is getting bigger. Yeah. What exactly is going on with me, doctor?
Okay, so at the moment, what I'm thinking about that we call acromegaly. Don't bother by the name. So this has happened if there is a specific specific hormones in the brain, or in what we call the pituitary gland. So if there is any affection in that, if there is an excessive excretion of that hormone called growth hormone, usually it can cause this problem. Now I didn't have enough time to examine your eyes, but from what you're telling me, that it sounds to me that there is a tumor type. It can compress on your eye nerve, the cable behind of the eye, so it can cause these symptoms of blurring of vision and everything. So what we're gonna do at the moment? First, we need to run some blood tests and we do some imaging. And then I will consult my consultant, the endocrinology consultant, to see more. And we refer you also to the eye doctor to have a proper examination and to your eye, and we let you know about all these things. At the moment, I don't think that we can do all this as outpatient. No need to be admitted to hospital, as far as you are not you are keeping yourself hydrated. Is that okay? Does that sound good for you?
Yes, doctor. Yes, thank you.
Okay, and also we discussed with the occupational therapist, the occupational regarding your job, because we think that your symptoms affected.
Yeah, and how can you help me with my libido? My erection is really, I'm really.
Okay, as far as we reach the diagnosis, we confirm the diagnosis. At that time, we can treat this is a tumor. Most probably, it will be like surgical removal of this tumor, and then your hormones will get more better, and your symptom will be helped by that.
Okay, thank you so much, doctor.
Thank you.
Yeah, time is up. Let's go to the examiner questions. Well done.
Okay. Well done. Could you summarize the patient, Dr. Maida? Well done.
Okay, so this is a 48-year-old gentleman presented with a polyuria and fatigue. He has eye symptoms. He has blurring of vision, and he has some facial changes and big hands, large hands. He also had high blood pressure and headaches. So the whole picture sound like acromegaly, giving this collection of symptoms. From that, we need more investigation to confirm the diagnosis and treat the complication.
So, what are the other differentials?
Okay, so for polyuria and polyuria and fatigability, diabetes is one of my differential diagnoses, and it sounds also it can be one of the complications of the acromegaly. The second differential diagnosis of this patient having polyuria and high blood pressure, it can be diabetes insipidus. Is still one of the differential. Also, hyperaldosteronism, it can be one of the differential, and acromegaly is in the top of the differential diagnosis.
Okay. So how will you investigate?
Okay, so I will start with a bedside investigation. This is include blood sugar, and then I will do ECG for this patient, then blood test, the blood test, CBC, urine function, renal function, and I need to do as well urine dipstick for this patient. I'm really interested for the electrolytes, including calcium, potassium, and sodium in this gentleman. Then a specific investigation to confirm the diagnosis, growth hormone level. I will be interested in thyroid hormone and other pituitary hormones as well. And imaging, I will do imaging CT for pituitary, and this is the investigation.
Okay. In terms, what are the complications that you have been looking out for in this patient? And
Okay.
did the patient have any complication?
Yeah, so side vision. So this adenoma can compress on the optic chiasma and causing even blindness. So this is one of the complications. Uncontrolled diabetes and uncontrolled hypertension with and high high intracranial pressure.
Okay. So how will you manage?
Okay, so I will start with non-pharmacological treatment by education of the patient, explaining the disease for the patient, and managing the dietitian advice regarding managing of blood sugar, and advice in diet for high blood pressure as well, for low sodium diet. I also, okay, this is non-pharmacological. Pharmacological treatment. I think it's mainly surgical, isn't it?
Okay. So this gentleman has a skin rash. What do you think it is?
Acanthosis nigricans.
Okay, well, so what are the other causes of acanthosis nigricans?
Metabolic syndromes, Cushing syndrome, and obesity, and diabetes. All this can cause acanthosis nigricans.
Okay. All right. I think those are the questions I have for fun. Thank you.
Thank you.
I have 15 seconds for you, Dr. Maida. Tell me the mechanism of polyuria in this patient. Two mechanisms.
Polyuria in patient with acromegaly. Okay,
Yes.
it can be secondary also pituitary hormone. It will be secondary to what do you call?
Syndrome
ADH.
of inappropriate.
Yeah,
Okay, antidiuretic.
yeah, antidiuretic hormone, SIDH. It can be secondary with diabetes, because this patient he may have diabetes as well.
Yeah, so in order, what's the first possible differential?
Diabetes.
Yeah,
And
so
then,
put diabetes before anything else.
Mm.
Diabetes and what do you think the second?
SIDH.
Okay, although it's not the most common, but what else?
Diabetes insipidus as well.
Yes,
Mm.
diabetes insipidus, rather than SIADA.
Mm.
And one more, patient present with renal colic, tummy pain.
Hypercalcemia.
Yeah, that's enough. Okay, yeah, fair enough. Okay, thank you, Dr. Maida. Well done. Let's hear Dr. Ayula, then I will comment.
Yeah, thank you, Dr. Maida. That was quite good. The history was good, and examination was focused. Especially though you missed the high initially, I would have shown you the bitemporal myopia that he had, that he had, sorry, but you eventually mentioned that, which is good. Just a few some observation. The history-wise, patient told you he has renal colic, abdominal pain, and you're also thinking that there might be something in the pituitary. Why didn't you put? I just was thinking that what are another differential that you will have thought of in this gentleman?
Yes, this hypercalcemia.
Yeah.
Symptoms, yeah.
Yeah. Putting all this together, is there anything that will be going through your mind as a possible diagnosis here?
Especially with the hypercalcemia, joint pains, and back pain, you mean?
Yeah, he has features of hypercalcemia. He has hypercalcemia, tummy pain, as well as a possibly of acromegaly, a mass in the brain. A pituitary mass, to be precise.
Yeah, it's in my mind, but the word is not coming out.
Multiple endocrine neoplasia, possible type 1.
Yeah, men. Yes.
Men 1. Yes, I think that would top the chart of the differentials, possibly the differentials here. Yeah, and then the treatment was, the diagnosis was, I mean, the management, the history was fine, diagnosis was fine. I mean, the examination was good. I will have added that men as part of my differentials as well, and then we'll have talked about possibly the surgical. You talk about the surgical management for acromegaly. What is the name of the surgery? Do you know?
It's not coming. I didn't remember. It's through the nose.
Yeah, transsphenoidal resection of the pituitary. Of the transsphenoidal resection. That is what and you yeah. Okay, you did mention of other hormones in the that you check for the other hormones in the pituitary. I mean pituitary hormone, which is good. So, but in the order of preference, if you want to, let's say this patient had deficiency of the pituitary hormone, in order of preference, how would you replace these hormones? Did you get what I mean?
Yeah. So the growth hormone, it will be higher. So the first, I didn't remember that. I didn't remember the order, to be honest.
Yeah, just in terms of their needs in the body, cortisol. Remember cortisol, then thyroxine, then you can then look at other like testosterone, just in terms of their metabolic needs. Hello?
Yeah, the same, the order of the hormone itself in the pituitary gland. I mean, I will start ACTH, the cortisone, so ACTH, and then thyroid hormone.
Yeah. Okay. Thank you so much. I'll leave it to Dr. Bassett. Thank you.
Thank you.
Yeah, thank you, Dr. Ayola. Good case. Thank you, Dr. Maida. Well done. That's the case of men. It's a shocking diagnosis at the end, right, Dr. Maida?
Yeah.
Yeah, what do you think the clue of the scenario?
He had three things: pituitary, pancreatic, and I need to think about the pancreatic, that he has hypercalcemia symptoms.
Parathyroid, not pancreatic. So, no pancreatic here. Or diabetes, Dr. Ayola, you want to say diabetes or diabetes due to acromegaly?
The diabetes is due to acromegaly.
Yeah, I think no pancreas here.
They would usually have insulinoma, if at all. Gastrinoma, insulinoma.
Gastrinoma, yeah, tummy pain, you mean? Yeah, okay, good. Yeah, tummy pain, yes. Yeah, and the clue here will be also confirmed by family history, right? You will have a family history of cancer if you ask in details the family history. Is there any family history of same condition? Any family history of cancer? Any family history of brain cancer? Right? It's supposed to be there, right, Dr. Maida?
Yeah.
What's the mode of inheritance?
Autosomal dominant.
Yeah, and what is the gene?
I don't remember.
Ret gene, ret?
I think IRA gene. I think IRA is for the autosomal polyglandular type 1.
No, this is different. Polyglandular is different than men.
I know, but I'm just thinking that the IRA gene is for that. I'm not quite sure, but I think it's for the polyglandular syndrome. But I can't honestly. But I think so.
No, it's red gene.
Okay,
Red
all right.
gene, yeah. Red.
Yeah, got it. Yeah. Okay, red
Yeah.
gene. Yeah.
Yeah, red gene.
Yeah, thank you.
Yeah, so you will have three components or three items: pancreatic, parathyroid, and the pituitary. As Dr. Maida did, but I think Dr. Maida also still it's not well organized because you jump from here to there, right, Dr. Maida? Do you think? But the good thing,
Yes,
Dr.
yes.
Maida,
So,
yeah, because it's confusing. Really, it's difficult scenario to have a disease of mixed or multi-organ injury. It's difficult to catch and to pick up the findings regularly without these questions, which would be disorganized. Anyway, you will try to be organized as much as you can. You will not be perfect, you will not be at the optimum, but you will try to do in a systematic way. Why? Because if you ask in such way, the first comment in the communication skill, disorganized. Believe me, the examiners commenting on this. If you ask from the head, then the tummy, then the skin, the joint, so you have to be organized from the head downwards. This is what I believe and what I prefer. But the good thing in this scenario, you didn't miss the sexual history. Although you went deep in the sexual history, you asked a lot of questions in the sexual history. You can ask simple questions or less questions. You have any problem with this? Yes, okay. So we can address this. But it's good to explore it because this patient will have the impotence. What do you think the cause of impotence, Dr. Maida? This is another question. The impotence in this scenario. What the cause of impotence, Dr. Maida?
hormone. The
Yeah.
sexual hormones. If
Okay, this is
DHA,
first possibility from up from the pituitary. What else?
growth hormone itself.
Yeah, the or prolactinoma if there is associated high prolactin, and the growth hormone can cause fatigue. Yes, and one more. Yeah,
Sexual
very
hormones.
important.
I mean,
You already mentioned the sexual hormone, FSH, LH. Yes, I agree. Yes, gonadotrophin. Yes, gonadotrophin deficiency. No, what else? Something else important and common as a complication due to the disease, the acromegaly, the complication of acromegaly.
diabetes.
Yes, exactly. Maybe the diabetes will be the cause. Imagine, rather than the FSH, the prolactinoma or whatsoever. Why? Because the diabetes in acromegaly is very common. It might be for longer duration, and it might lead to macro and microvascular complication, either impotence or other complication of diabetes. This patient or those patients might live with the high blood sugar, with the manifestation of blood sugar and hyperglycemia, because the cause is there. You have to treat the cause, which is acromegaly. Whenever you do the surgery, maybe the blood sugar and everything will be controlled. But the blood sugar and the blood pressure will be difficult to control as long as there is acromegaly. Okay? I think the case was clear, and Dr. Ayula gave you good clue initially when she told you, I noticed my hands was bigger. And by the way, the examination was target. You did examination of the manifestation of acromegaly, but the hand you forget. Start by general look, I agree, but you have to also ask for the vitals and the hand size. Put your hand beside the patient hand in comparison. So you will say it's bigger than my hand. The sweating. So the all peripheral manifestation you forget. Sweating, finger prick marks for blood sugar, and the pulse. The patient might have already. You have noticed the heaviness in his pulse, or he has high pulse volume, right? The skin tags you miss, right? There is numbness in the hand. What do you think the cause of numbness in the hand? Tingling and numbness.
Um,
Yeah, please mention it.
carpal tunnel.
Yes, exactly. Carpal tunnel syndrome. So you have to ask, can I tap? Do you have any pain here? Then you can tap, and the patient will tell you, yes, I have pain in the lateral side of my hand. Okay. This is regarding the peripheral signs of acromegaly: skin tags, sweating, pulse, hand size. Sometimes, maybe in the hands, the joint pain, but and in this scenario, I think osteoarthritis, right? Anyway, back to the vitals, the blood pressure will be high, the blood sugar as well will be high. Maybe you have paroxysmal myopathy, right? As acromegaly. Then the head examination, the vision. It's important here to know what the cause of his vision problem. Is it blaring? You said blaring of vision, right? But you didn't ask clearly how is the vision by the history and the examination. But the good thing you said, I would like to continue my examination by doing the visual examination. What do you think the possibility of vision affection in this scenario? Give me two possible complications.
Okay, temporal hemianopia,
Perfect. By temporal hemianopia, due to
chiasma, the optic
pituitary
chiasma compression.
macroadenoma.
Yeah.
Pituitary macroadenoma. The second possibility of vision affection.
Okay, diabetic
Exactly.
manifestation.
Yeah, diabetic retinopathy. Or cataract due to also diabetes or whatever. But these are the possible vision affection in this scenario. So you have to ask clearly, have you ever bumped into the object? The patient will tell you yes. Or have you ever, if you are driving, have you ever hit the mirror? He
I
might
think
tell you yes.
by the driving thing, I need to.
Yeah, see, now you remember the day.
No, I don't.
Yeah, always, always, whenever you have vision problem while taking history, either to write it in paper that the vision is affected or to address it immediately. Why? Because you'll forget. So if I ever hear the patient is having vision problem, I will ask him, do you drive? Instantly. Yes, please, can you stop driving until we confirm the diagnosis? Why? Because I will forget it, definitely. Unless I will ask in detail the social history, the job, do you smoke, do you drink alcohol, do you drive? If you wrote it in the social, you will remember it. But if you don't, you will forget it. So either to do this or to do that. If you double checked it here and there, it's okay. But at least don't forget it. It's one of the welfare points, and they might mention it in the bold lines. Patient forget driving address. Okay. Next, so the other or the next examination in the face, as you examine the frontal bossing and the facial, all facial, coarse facial features, the tongue, wide spaced teeth, and the prognathism. So you can look at beside the patient to his mandible. It will be protruded out. The tongue, big tongue. One doctor mentioned the obstructive sleep apnea as a complication. You can ask it if you remember. I believe it's difficult to remember all these complications. Anyway, if you remember, you can address it. What do you think the cause of obstructive sleep apnea in this patient? Dr. Maida.
Large.
Yes, large tongue. Yes, large tongue or the upper airway obstruction. The large neck as well. Okay, the hypertension. This is another question in PACES. What are the causes of hypertension in this patient? Give me three. Acromegaly, yes, the first. The second?
It's part of men.
Part of men,
Or
hypercalcemia. It's not cause of hypertension. Yeah, no, it's not the cause. There is another cause. Hypertension. Obstructive sleep apnea. Right? Obstructive sleep apnea, one of the cause of hypertension. Or sorry, headache. Yeah, the question is headache, not sorry. Let's repeat the question. What are the cause of headache in this scenario?
Yeah, obstructive sleep apnea.
Yeah, sleep apnea.
And high blood pressure.
Yes, hypertension and macroadenoma.
Macroadenoma.
Yeah, local cause. Yes. So this is the question, not the hypertension. Anyway, the causes of hypertension, yes, as you said, acromegaly can lead to hypertension. Okay, the next step of the examination, the neck for the skin tags again, or acanthosis nigricans. Raised GVP, you can notice it might be high cardiac output patient with acromegaly. Cardiomyopathy might be as a complication, right? Then the apex beat is it displaced, might be due to hypertension. The other murmurs you can examine quickly. I think these are the manifestation in the chest. You can auscultate the chest quickly, but yeah, loud B2 for primary hypertension, the heart failure signs and symptoms, the murmurs. The organomegaly here you have to examine for any organomegaly because it might be complicated, right? Cancer colon, one of the complication, you might either ask it or offer to do rectal examination, digital rectal examination for cancer colon as a complication, of course. Sometimes they have blood or melena through the back passage. So you have to remember this complication. It's very big topic. The acromegaly itself, or add to them the men type 1 exactly. It will be more wider of symptoms and manifestation and complication. So you cannot have the time to do all these screening. At least do the most manifested symptom, which is acromegaly. The complication of hypercalcemia, don't forget, renal colic, polyuria, polydipsia, the mood change, you have to ask while asking about CNS manifestation, the sleep mood, if he's sleeping well or no. All this might be affected due to hypercalcemia. Abdominal pain also one of the manifestation, joint pain, muscle pain, and bone pain. Okay, try to make the things organized from the question during the systemic review. But for the polyuria itself, you examine, you take a good analysis of the complaint, the polyuria, and the compensation. Always remember it. Are you compensating when you are hydrating yourself well? Why? Because if this patient passing a lot of urine without compensation, he might be dehydrated. Okay. I think I cover most of the point here. Don't forget the specific investigation here, the genetic testing, one of the important screening you have to do. Okay. Those patients also might put under program for cancer colon survey, right?
Yes.
Yeah. I'm trying to remember the important points. However, it's as I said, big topic, but it's very common to come in cases. Men type 1. And it would be the same presentation as Dr. Ayula presented. So either headache or diabetes, uncontrolled hypertension. Then you can ask the other question. You will have the other manifestation, hypercalcemia, acromegaly, and gastrinoma, recurrent abdominal pain. Put it on the top of your differential. Then you can mention every complication alone, like acromegaly itself as a complication or as a differential. So you will mention main type 1, first differential, acromegaly, and diabetes with polyuria. So do it in this order. As a differential, I'm talking about differential diagnosis, okay? Any question, Dr. Maida?
No, thank you. Cover everything.
Yeah, any comment you want to add? Dr. Ayula, anything missed? Echo and ECG
No,
already
thank
mentioned.
you.
Yeah, okay, thank you, Dr. Ayula. The echo and ECG as bedside, urine dip, ABG, all the things. And the specific for acromegaly, don't forget, screening
Thank you.
for growth hormone level, and the specific to confirm the diagnosis is how to confirm
Glucose tolerance, oral glucose tolerance test.
growth
OGTT.
MRI.
hormone. No. MRI as image. It's the specific blood test for growth hormone acromegaly. What is it?
The OGTT, regular glucose tolerance test, and growth hormone measurement.
Growth hormone for screening. For confirmation, oral glucose tolerance test. Yes. Okay. And insulin-like growth factor, right? Insulin-like
That's
growth
for the
factor.
screening, yeah.
Yeah, this screening also. Okay. So the insulin growth hormone-like factor we mentioned, and the oral glucose tolerance tests we mentioned, the MRI as an image, the complication, of course, all of them you can mention as diabetes, hypertension. Diabetes, of course, you have to mention hemoglobin A1C, fasting, and random blood sugar. The other hormones for pituitary is one of also important investigation to do. The carpal tunnel, don't forget, nerve conduction study. Obstructive sleep apnea, you can mention polysomnography, echo for cardiac output failure. The calcium level, yes, all electrolyte here is important, including calcium in the blood and in the urine. Okay, I hope I didn't miss any, as well as Dr. Ayula, about this topic. Anyone want to comment or add comment, any suggestion? Okay. Let's read the comment quickly. Yes, the steroid. Always remember the steroid is the most important hormone in our body. So you have to replace it first before anything else. If you start to correct the thyroid without the steroid, you might have Addisonian crisis. Remember this from Addison, the patient. So you have to start correction with the steroids. This is regarding the question of which hormone you should replace first if this patient have surgery and he went into hypopituitarism or panhypopituitarism, panhypopituitarism as a complication. Okay, the comments. Obstructive sleep apnea, nipple discharge. I don't think this patient is having prolactinoma. It's acromegaly, straightforward. But I don't know to ask about nipple discharge. I don't think it's important, this scenario. You can ask about it if you suspect prolactinoma. Diabetes in history, yes. Tumor is jargon, I agree. So you can ask, you can say overgrowth. Okay, don't say tumor. So overgrowth means either cancer or benign. Then you can explain it later. I think the differential acromegaly as part of men, of course. I think hypercalcemia, yes. Perimetry, I agree, okay. Mode change, steroid. Other treatment option, big bismuth, yes. Octreotide, dopamine agonist, plus radiation, yes. So you can mention the options or the pharmacological option. These are the pharmacological options. But the first and the definite treatment here is surgical, which is transsphenoidal surgery or resection of the acromegaly, of the macroadenoma. The gastrinoma, MEN1 gene, yes. Okay, MEN1 gene, not RIT, sorry. RIT for type 2, thank you. Yeah, thank you, Dr. Goda. I always mix both of them. So the RIT for MEN2, for MEN1, it's MEN gene. Okay, Dr. Ayula and Dr. Maeda, because I mentioned it earlier. So RIT gene for type 2, MEN type 2, MEN gene for MEN type 1. Thank you again, Dr. Goda. Diabetes, yeah, insulin growth factor, screening, oral glucose tolerance tests with growth hormone measurement for confirmation. Thank you, Dr. Ayula. Thank you, everyone. Anyone has comment before ending the session? Any doubt, any suggestion, any comment? Feel free, please, to comment. It's not a meeting for me only or the participants. It's meeting for all of you. So anyone has a comment, please feel free to comment anytime. Any question before ending the session? Again, thank you, Dr. Ayula, Dr. Mayada. See you, inshallah, next session, the communication session. Thank you, everyone. Thank you for the attendance. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.
Thank you so much.
Thank you.
Yeah, but for colonoscopy too might be important, please, because of
Sorry?
colon tightness. Yeah, thank you.
Yeah, I already mentioned the colonoscopy.
Okay,
Yes.
all right.
This
Yeah, I
patient
think I
should
missed
be
that.
screened. Yeah, I mentioned already. Yes.
All right, thank you so much. Yeah.
Thank you too. Thank you. Good luck and good night. Assalamu alaikum.
Bye.